There are three general areas we will cover. The first is a discussion of what the definition of an intellectual disability is, what is generally covered when assessing for an intellectual disability, and what criteria are used. The second area we will cover has to do with an individual having more than one diagnosis. It is in fact quite common that the child or adult with an intellectual disability will actually have two or more diagnoses. We will spend some time discussing several of the more common combinations of diagnoses that specifically relate to the core issues of an intellectual disability. We will not be discussing in much detail any medical or mental health concerns. While these issues are very important, they take us beyond the specific focus of what an intellectual disability is. Finally, we will be discussing how to use such information. Any information we collect regarding an individual needs to have a purpose. We will discuss some of the ways in which the information gathered regarding the diagnosis of an intellectual disability can be useful in planning and providing services for people with such a disability. The current definition used in the Diagnostic and Statistical Manual, DSM, of the American Psychiatric Association has three criteria for defining an intellectual disability. These criteria are a deficit in intellectual functions, such as reasoning, problem-solving, planning, abstract thinking, judgment, academic learning, and learning from experience, confirmed by both clinical assessment and individualized, standardized intelligence testing. Second, are deficits in adaptive functioning that result in failure to meet developmental and social-cultural standards for personal independence and social responsibility. Without ongoing support, the adaptive deficits limit functioning in one or more activities of daily life, such as communication, social participation, and independent living across multiple environments, such as home, school, work, and community. And these all have to have an onset of the intellectual and adaptive deficits during the developmental period. Descriptors of the level of disability are generally based on the results of standardized assessments, which have a mean or typical score of 100 and what is called a standard deviation of 15 points. So 2 or 3 standard deviations below the mean, or roughly a score of 70 to 55, is classified as mild. 3 to 4 standard deviations, or scores between 55 and 40, classified as moderate. 4 to 5 standard deviations, or scores between 40 and 25, are in the severe range, and scores below that are typically thought of as being in the profound range. Taken together, this means that in theory, approximately 2.5% of the population could be diagnosed as having an intellectual disability, although there are variations that occur locally and across different age groups. You can also think of the scores in terms of what is called percentiles. Percentiles tell you the relative standing of a score compared to how everyone else did on the test or assessment. For example, a standard score of 70 on an IQ assessment would translate into the second or third percentile. This means that 97 to 98% of all the people in the normative sample for that assessment scored higher. For a person with a moderate intellectual disability, their score would suggest that over 99% of people would score higher. As you can see when looking at these assessment scores from a percentile basis, the intent of the definition of intellectual disabilities is to find people who very likely will need some ongoing assistance in managing a range of cognitive, intellectual, and adaptive demands placed on them in everyday situations. DSM-5 does not give specific numeric criteria for assessment of adaptive behavior as is given for intellectual testing. It does, however, recommend the same combination of using standardized assessments and clinical evaluation as for IQ assessments. For formal assessments, it is again often easier to understand the meaning of the outcome using percentiles. It has the same meaning as described regarding assessments of intelligence. Most adaptive assessments are scaled identically to intelligence tests, with a score of 100 being the average. A score of 100 is equivalent to the 50th percentile. As mentioned in the previous slide, percentiles tell you the relative standing of a score compared to how everyone else did on the test or assessment. For example, a standard score of 70 on an adaptive behavior assessment would translate into the second or third percentile. This means that 97 to 98% of all people in the normative sample for that assessment scored higher. For a person with a moderate adaptive disability, their scores would suggest that over 99% of people would score higher. Again, it is easy to see when using percentile scores that the intent of the definition of intellectual disability is to identify individuals who very likely struggle to meet everyday expectations for adaptive behavior capacities. So how many people have an intellectual disability? In real life, as compared to what statistical theory suggests, it is not so easy to get an exact number of people who actually have an intellectual disability. When studying children and adolescents, the rates across studies has varied from 2 to 6%. The rates typically found in adulthood are around 1 to 1.5%. Part of these differences is clearly reflecting the cognitive and behavioral demands between school and adult life. What environment you live in can impact the prevalence rates. It was mentioned earlier that a score of 70 on the type of assessments we are talking about translates into about 2.5% of the population having scores of 70 or lower. The actual prevalence rates in adulthood generally tend to be lower than this. One reason for this is that the definition of an intellectual disability requires that the individual score below 70 on both an IQ and an adaptive behavior assessment. Having to score lower on both assessments lowers the actual prevalence, as there are people who score below 70 on one assessment and above 70 on the other assessment. As well, people with milder intellectual deficits may in everyday life be doing very well adaptively if they are living in a naturally supportive environment. People with profiles such as these would not be considered to have an intellectual disability as defined by DSM-5. Throughout this presentation, the scores are given in exact scores. In reality, there is what is called a measurement error, meaning that, for instance, a score of 70 means the person's true score is very likely to fall in the range of 73 to 67, depending on the assessment instrument used. The formal diagnostic definition does take this into account, leaving room for the clinical judgment of a well-trained psychologist. This measurement error also contributes somewhat to the differences in prevalence rates found between studies. In the last 25 years, such terms as mental retardation, developmental disability, learning disability, mental handicap, mental deficiency, and intellectual disability have all been used to express similar operational definitions. Making sure that you're clear on the actual definition people are using when they use these and other terms will help you keep your conversation clear. For example, the current DSM-5 uses the term intellectual disability, while the previous version used the term mental retardation. And while there are some changes from DSM-4 to DSM-5, the essential concept is the same. In the current edition of DSM, for instance, there is a change related to more formally emphasizing the need for comprehensive clinical evaluation over and above simply just doing the intellectual assessment tests. As well, the criteria for defining problems in adaptive behavior is somewhat milder than in the previous edition, suggesting a recognition that presently it takes less disruption in a person's everyday life to lead to actual disabling levels of difficulties than has historically been the case. There is essentially no difference regarding the use and interpretation of IQ testing. Because there is this variation in terms, both over time and across different jurisdictions, keeping in mind the formal definition and criteria you are using will make it much easier to understand the similarities and differences regarding who is being discussed. Intellectual and adaptive behavior assessments provide an overall outcome as well as a set of more specific scale or domain scores, and even more specific subtest scores. The global or general composite scores tend to be the most stable and more likely to be predictive of certain likely capacities in the future. The composite score is typically a weighted average of all the subtest scores. Fairly routinely, they are used to make determinations such as eligibility to programs or services. Domain or scale scores are made by combining scores on two or more subtests that have been found to assess a common area of functioning, for instance verbal comprehension or social skills. These scores start to provide more meaningful details regarding a person's areas of strength or weakness. Subtest scores give even more detailed information than domain scores. For instance, verbal comprehension can be looked at in a variety of ways, such as knowing answers to factual questions, being able to manage more abstract information, such as how two words may actually have similar meanings, or have meaningful conversation. Psychologists, when given the opportunity to assess a person over time, also look closely at the person's raw scores. It is expected, for instance, that over time a person's raw scores will improve, even though the formally reported scores may suggest no improvement or even an apparent decrease in skills. Real actual loss can at times be a red flag for serious problems. Used properly, IQ assessments give more detailed information that can be used to make some overall guidance to questions of likely capacity. However, by itself, IQ assessments are not terribly useful for deciding on possible intervention options. Adaptive behavior assessments, used properly, can be used to inform intervention plans of what skills have already been acquired. The recommendation in DSM-5 that such assessments be part of a comprehensive evaluation of the person clearly indicates that such information is most useful as part of an overall assessment of the person. Much of the philosophical focus of services for people with intellectual disabilities is on assisting the person to lead as normal a lifestyle as possible. Understanding how the person performs relative to a normative sample is thus imperative. Both adaptive and intellectual assessments provide information regarding this question. While clearly a much more in-depth analysis of local normative behavior is necessary for good planning, both intellectual and adaptive behavior assessments give an overview of how well the person is likely going to be able to meet typical expectations. While more serious intellectual disabilities appear early in a child's development, it is quite common that a child who will end up having a mild intellectual disability will not be diagnosed until they are in their teens. This can cause some confusion, particularly if the child is being assessed at an earlier age, often due to concerns regarding their learning. Children may be found to have an overall IQ in the low average range if they are assessed in kindergarten to grade 3, and in the borderline range if assessed in grade 6 or 7. Often this is where assessments stop, as it will be apparent by that point in time that the child is a slow learner or appears to have a variable overall profile with some areas of relative strength and weaknesses. Depending on the school supports, as the child enters middle school and high school, they will tend to spend more and more time in resource room programs or taking modified coursework in the regular stream, often with extra classroom support. The following two graphs are simplified versions of what this process actually looks like. As well, no child would be assessed on an annual basis as suggested in the graph. Please be aware that all these scores are made up for this demonstration. It is important to understand that there are two types of scores. The first is the raw score, which is the total number of items on the assessment the child did correctly. This score is then converted to what is called a standard score, which, besides other things, allows scores to be compared over time and across individuals. This first graph showing the raw scores indicates two things. First, both lines are increasing. That is, a child who will be diagnosed with a mild intellectual disability, as well as the typical child, will show gains in competency over time. Second, you can see that while there are ongoing gains, that the typical child tends to gain faster year after year compared to the child with an intellectual disability. The second graph translates these raw scores to standard scores, in this case IQ scores. Again, there are two main points. The first is that for the typical child, their IQ remains stable over time, even though looking at the raw scores, it can be seen that they gain skills every year. Essentially, for IQ assessments, as with a wide range of other child assessments, the child needs to gain an expected age-appropriate level of skill to remain with the same standard score. The second point is that you can observe that the gap is widening over time between a typical IQ score and an IQ score for a child with an intellectual challenge. This results in the standard score for the child with an impairment falling relative to his or her age peers, even though, as seen in the raw score graph, they are gaining skills every year. It is simply that they are not gaining skills at an age-appropriate expected rate. Particularly if there are services available for adults with mild intellectual disabilities. These graphs demonstrate that it would be very important to complete an intellectual assessment in the late teenage years to ensure that all individuals who would be eligible for such services are assessed to establish eligibility. Using out-of-date IQ assessments from when the child was younger will in fact miss many individuals who would actually be eligible for adult services. Why care about the developmental criteria? Regardless of the age of the person, it is possible that they will have scores on an IQ and adaptive behavior assessment that clearly suggest significant impairment. Adult onset problems such as strokes, mental health problems, dementia, and brain injuries can all result in IQ and adaptive behavior assessment scores indicating significant areas of impairment. This fundamental belief that regardless of the test scores at any point in time, there is a difference if the scores are produced by a developmental disability compared to an adult onset disability is based heavily on the interruption in development caused by the disability occurring during the developmental period. Adults who are injured or otherwise develop such severe impairments have had years of typical development and experience behind them until the point of disability. Adults with intellectual disabilities will have had some or all of their developmental period affected by the disability. They will have had little to no years of typical development. This belief is borne out in the reality of service delivery. Not only do most jurisdictions have separate streams for developmental disabilities compared to adult onset disabilities, but even when there's overlap, typically service providers provide largely separate programs. As an example, for all intents and purposes, most individuals with moderate to severe dementia will have IQ and adaptive behavior scores below 70. Many nursing home staff talk about the difficulty in managing individuals with an intellectual disability that may be placed in the home, mostly because of a lack of fit. Just to bring the whole point home about the difference between an intellectual disability being defined as originating in the developmental period compared to an adult onset disability, let's look at a simple example. Person A. Person A is age 32, has an IQ of 67, and an adaptive behavior score of 59. Person B also is age 32, has an IQ of 67, and an adaptive behavior score of 59. Diagnostic information. Person A was diagnosed with an intellectual disability at age 10. Person B, at age 25, was drunk, crashed his car into a ditch, and became a near drowning victim. While the scores are obviously the same, we quickly start to view the two people as being quite different. Not only does this example demonstrate how critical it is to differentiate between the developmental period versus adult onset disorders, it also introduces the whole concept of the range of diagnoses that may co-occur with or cause an intellectual disability. The distinction between diagnoses that always or virtually always cause an intellectual disability, sometimes may or may not cause an intellectual disability, or seems to co-occur as a separate diagnosis with an intellectual disability, confuses many people. One of the more complex issues arises from a diagnosis that, depending on their severity level, may or may not cause an intellectual disability. There are causal factors such as brain injury, fetal alcohol spectrum disorder, and Fragile X that have wide-ranging effects and levels of effects. This means that many people with any of these conditions, while possibly showing obvious difficulties, do not in fact meet the criteria for an intellectual disability. In such cases, you could in fact have two affected siblings, one who also has a diagnosis of an intellectual disability, while the other sibling does not. Both, however, are affected by the original biological disorder, for instance, fetal alcohol syndrome. This will lead one of the siblings to be eligible for a range of services the other sibling is not eligible for. On a simple functional basis, it may be that both siblings need fairly similar types of support, however. One sibling may get services while the other sibling does not. For diagnoses such as autism that does not appear to cause an intellectual disability, but rather has a relatively high likelihood of co-occurring with an intellectual disability, it sometimes becomes very confusing for people to understand how co-occurring disorders should be discussed. For instance, it is not infrequent to hear discussions about a child with severe autism who in reality has a severe intellectual disability and possibly relatively mild symptoms of autism. This is compared to a child who has above average intellectual capacities but demonstrates very severe symptoms of autism. The severe autism in these two cases is obviously vastly different. Down syndrome has a near 100% rate of causing intellectual disabilities, at times quite severe. It's important, however, to remember that there are rare cases in which an individual with Down syndrome, usually someone with mosaic or translocation Down syndrome, instead of the classic full trisomy 21, who does not have an intellectual disability. Besides brain injury, fetal alcohol syndrome, Fragile X, autism, and Down syndrome, there are many other conditions that are known to either cause an intellectual disability or are relatively commonly associated with an intellectual disability. The list of known causes of intellectual disability is increasing all the time. Improved medical and genetic evaluations are the biggest reasons for the growing list of known causes. For instance, fetal alcohol spectrum disorder and Fragile X, as being major causes of intellectual disability, were barely known 30 years ago. Most of the new causes for an intellectual disability, however, are for relatively rare genetic disorders. There are now many known diagnoses for an intellectual disability. In fact, there are now over 1,000 known disorders that are linked to intellectual disabilities. How many of these diagnoses do you think actually have specific behaviors that are virtually unique to the diagnosis? As the following list shows, there are very few diagnoses with diagnostically unique behaviors. Thus, from a behavioral perspective, a medical diagnosis rarely suggests a specific behavioral concern. For instance, not all children with autism engage in problematic self-stimulatory behavior, while some children with Down syndrome do. One of the issues to recognize is that from a cognitive and behavioral perspective, this very small list of unique behaviors associated with a diagnosis means that the vast majority of cognitive and behavioral capacities, difficulties, and challenges can and will be observed to occur across any number of individuals with intellectual disabilities caused by a wide range of genetic, chromosomal, or other disorders. However, this does not mean that various disorders that either cause or co-occur with intellectual disability are not known for having higher than expected rates of some types of behaviors. Self-stimulatory behavior is commonly associated with autism. Skill sets termed executive function capacities are frequently impaired for individuals with fetal alcohol syndrome. Either of these difficulties, of course, occur across a fair range of individuals with intellectual disabilities, which is why they are not used as a specific diagnostic criteria. This is the case for most other behavior concerns or skill deficits. Medical diagnoses are important for alerting you to the possible range of physical and neurological concerns that may be associated with a specific diagnosis. For some diagnoses, there is also some information describing the course of the disorder, for instance, Rett syndrome or Fragile X. As well, for many parents and for some individuals themselves, having specific diagnostic information can be critically important for the individual's psychological well-being. A diagnosis of intellectual disability gives valuable information that provides some general guidelines or context for discussing many other functional issues. While each individual will have their own unique profile, the diagnostic information will provide guidance on a range of topics, such as likely areas of strengths or areas of potential difficulties. There are also 3 types of diagnostic processes that can get confused. The medical diagnosis is focused on describing and verifying known biological factors, for instance genetic or chromosomal markers, underlying a diagnosis of an intellectual disability. It may also highlight potential related physical issues, for instance impaired gait, or sensory concerns, possibly vision impairments, and neurological issues, for instance the possibility of a seizure disorder. A psychological diagnosis focuses on defining patterns of behavior, skills, or abilities that present the core issues regarding the presenting problem. A psychological diagnosis will relate the observed behavior patterns to cognitive, intellectual, physiological, or emotional factors that are presumed to underlie the pattern of behavior. A behavioral diagnosis focuses on describing the functional relationships between the key behaviors of the presenting problem and the range of behaviorally relevant factors that determine the function of the behavior. Obviously, the professional making a diagnosis must be thoroughly trained in the appropriate assessment methods. It is highly unlikely that any one professional is thoroughly qualified in all 3 diagnostic formats. It is in fact quite unlikely to find a professional properly qualified in any 2 of these diagnostic formats. To be properly qualified, professionals need extensive training and supervised experience in using such assessments with individuals who both may or may not have an intellectual disability or underlying medical condition in order to gain specialized competence. For instance, it may come as quite a surprise, but many psychologists and physicians have neither the training nor experience to make such diagnoses. It is also just as clear that whoever receives the detailed information regarding the diagnostic information needs to be provided with a clear and adequate understanding of the information and how it is relevant to the person in question. Misuse and misinterpretation of such information, as compared to the information itself, continues to be an ongoing area of concern. The first part of this presentation has covered several basic issues. We discussed that there have been a number of other terms used in the past to describe what is presently called an intellectual disability. While the terms have varied, they have all been reasonably consistent in trying to define the diagnostic criteria for an intellectual disability. The 3 core features of an intellectual disability were outlined. They are limits in cognitive and intellectual abilities, problems in adaptive functioning in everyday life, and that such limits and problems started during the developmental period. While statistically approximately 2.5% of the population should meet the diagnostic criteria for an intellectual disability, the reality is that the rates vary noticeably, particularly over age groups. It is common to see a higher prevalence rate in childhood and a lower rate in adulthood. The case is made that the diagnosis can play an important but limited role in assisting an individual and parents, teachers, or others who may support an individual with an intellectual disability. It is important to remember that the diagnostic information, while important, will in most cases only be useful for giving broader or more general information regarding the person. Individuals, even with identical scores on the diagnostic assessments, will vary tremendously on a wide range of important factors and issues. The next 2 parts of this presentation will focus on the real-world complexity for many individuals with intellectual disabilities having 2 or more diagnoses, as well as a discussion of some of the common issues that occur when supporting an individual with an intellectual disability.